Good morning, good afternoon, and good evening to everyone who joins us from around the world. We're so glad you're here. This is Andrew and Renee. Welcome to the Stacks series.
Thanks for having me. It's great to be here.
Today, we are exploring perioperative pain management.
Which I know sounds like a huge mouthful of medical jargon right off the bat.
It really does.
But if you think about it, we're really just talking about one of the most primal experiences a human being can have. We are looking at the exact intersection of violence, because that is effectively what surgery is, and your nervous system's desperate attempt to survive it.
That is a hell of an opening. I mean, I think most of us listening have this very sanitized view of surgery, right?
Oh, absolutely.
You go in, the lights are bright, the doctors are calm, you count backward from 10, and you wake up fixed. We see it as this therapeutic healing ritual, but looking through the research we're going through today, that's not how the body sees it at all.
Not even a little bit. And honestly, that misconception is exactly where a lot of pain management has gone wrong historically.
Right.
We think of surgery as fixing something, but to your biology. Surgery is a controlled trauma. It is a physical assault on your tissues.
Your body doesn't know the difference.
Exactly. Your surgeon might have a PhD and the best intentions in the world, but your nociceptors, those are the tiny nerve endings that sense pain, they don't know that. They don't know the difference between a therapeutic scalpel removing a tumor and a knife in a street fight.
That is terrifying to think about.
It is the biological reality. The signal is identical. It's screaming, I am being attacked.
And the body just lights up.
When that incision is made, your nervous system lights up like a switchboard in a disaster movie. It reacts with this massive chaotic barrage of defensive signals. And for decades, the standard medical model was essentially, well, let's just put you to sleep so you don't remember the fight, and then we'll deal with the wreckage when you wake up.
The old wake up and groan model.
Yeah, the sledgehammer approach, it was entirely reactive. We literally waited for the patient to be in agony in the recovery room, and then we tried to chase that pain down with heavy drugs.
Which is wild when you think about the fact that we knew the pain was coming. We literally scheduled the trauma.
Exactly. And that is the crux of the paradigm shift we're seeing in the latest guidelines. We're moving from reactive to proactive.
So instead of chasing the pain, we're trying to stop the brain from ever fully realizing it got hurt in the first place.
Precisely. We are hacking the body's alarm system so that the physical trauma never fully registers as conscious suffering.
And the mission for our discussion today is to really unpack how we do that. We're going to look at the transition from that old sledgehammer approach to what looks more like a SWAT team approach.
A highly coordinated SWAT team.
Right. We're going to understand why using 5 weak drugs is actually better than using one massively strong one. And we're going to explore the cutting edge of prehabilitation, where we are actively preparing specific populations, kids, the elderly, people on opioids, with radically different playbooks.
It's a fascinating journey. It takes us from the raw chemistry of inflammation all the way to how your personal genetics dictate how you process codeine.
Let's start right at the base layer. Section 1. Foundations. What we think we know about pain.
To stop pain, you have to understand the journey of the pain signal, because it is not instant.
Even though it feels instant.
Right, you stub your toe and it feels instantaneous, but it's actually a relay race.
Okay, walk me through this relay race. Say I'm on the operating table or I just sliced my finger making dinner. What is step 1?
Step 1 is transduction. In your skin and your tissues, you have these free nerve endings called nociceptors. Think of them as the scouts on the front line of a battlefield.
Okay.
Their only job is to detect mechanical damage, a cut, a burn, crushing pressure, and they turn that physical event into an electrical signal.
So the scout spots the enemy and fires off a flare.
Exactly. And now that signal has to travel to headquarters, which is the brain. This phase is called transmission. But here is where it gets really interesting. Your body doesn't just have one type of cable for sending pain. It has 2 distinct types of wires, and they do very different things.
The A delta fibers and the C fibers. I remember this from the notes.
Right. Let's look at the A delta fibers first. These are the elite sprinters. They are myelinated.
And myelinated just means they have an insulating layer, right? Like a rubber coating on a copper wire.
Exactly like that. That insulation allows the electrical signal to skip along the nerve at incredible speeds. We're talking up to 65 miles per hour. This is the fast lane.
So when you touch a hot stove, your hand jerks back before you even consciously form the thought that it's hot.
Yes. That is the A delta fiber doing its job. It delivers that sharp shooting, highly specific pain that screams, get away right now.
It's pure survival reflex.
Pure survival. But then And you've definitely experienced this a second or two later. What happens?
The throbbing kicks in, that deep ache.
That's the C fibers arriving at headquarters. C fibers are unmyelinated. They are just skinny, naked wires.
So the signal is slower?
Much slower, about 2 miles per hour. It's basically the dial-up internet of pain signals.
Yeah.
But the message they carry is different. It's not pull away. It's lie down, don't move, and protect this area so it can heal.
That makes so much sense. The first signal prevents you from dying, and the second signal forces you to rest.
Exactly. Now, here is where modern medicine steps in. Both of these signals, the fast and the slow, have to pass through a specific checkpoint before they reach the brain. They go into the spinal cord, specifically an area called the dorsal horn.
The dorsal horn, the gatekeeper.
The gatekeeper. And this is arguably the most important concept in modern pain management, because for a long time we thought the spinal cord was just a dumb wire. You plug it in, the signal travels up to the brain.
But it's actually processing the data.
It is a highly complex computer. The spinal cord can decide to ignore a signal, or it can decide to massively amplify it.
It controls the volume.
It can turn the volume up to 11. This brings us to a phenomenon called central sensitization, or informally, the wind-up.
This part of the research totally blew my mind. The idea that pain actually breeds more pain.
To visualize it, think about a microphone and a speaker system at a live concert. The microphone is your nerve ending in the tissue. The speaker is your brain. And the amplifier sitting in the middle is your spinal cord.
Okay, I'm with you.
Normally, the volume is set at a reasonable level. You get a paper cut, you feel a paper cut. But during surgery, the microphone is absolutely screaming. It is sending a constant high-intensity barrage of A delta and C fiber signals into that amplifier.
And the amplifier just gets overwhelmed.
It gets structurally sensitized. The neurons in the spinal cord actually change their chemistry in response to the barrage. They start producing more receptors on their surface. They lower their threshold for firing. It's like the sound guy at the concert panicking and suddenly cranking the volume knob all the way to the maximum.
Which creates that awful feedback loop.
Exactly, the screeching feedback loop. Once that windup happens, the spinal cord becomes hyperexcitable. Even a tiny sound into the microphone comes out as a deafening roar.
This is allodynia, right? Where things that shouldn't hurt suddenly do.
Yes. Allodynia is when normal, non-painful stimuli like the hospital bed sheets just brushing against your leg suddenly feel like burning sandpaper. The amplifier is broken.
And once that feedback loop gets going, it's incredibly hard to stop.
It's nearly impossible to stop once it's fully entrenched.
Right.
You can throw all the IV morphine in the world at the patient, but the central nervous system is already caught in the loop.
Which perfectly explains why the old method failed, the reactive method.
If you wait until the patient wakes up screaming in the recovery room to start treating the pain, you have already lost the war. The windup has happened. The spinal cord is already reprogrammed.
So the entire goal of modern anesthesia, keeping those pain scores below a 3 out of 10 to ensure functional recovery, is to prevent the windup from ever starting.
Keep the volume knob down from minute 1. That is the mission. Block that barrage of signals before they can even reach the spinal cord and cause that chemical change.
Let's talk about how we actually do that. The transition from the old paradigm to the new standard.
The old paradigm was monotherapy. We relied almost exclusively on high-dose opioids. Morphine, fentanyl, Dilaudid.
And I mean, they do work, right?
Oh, they are incredibly effective at numbing the brain.
Yeah.
They bind to mu-opioid receptors and just turn the lights out. But the cost is massive.
The side effects are brutal.
Severe nausea, vomiting, complete bowel paralysis. But the biggest risk is respiratory depression. You literally stop breathing. If you give enough opioid to completely kill the pain of a major abdominal surgery, you very well might kill the patient's drive to breathe.
Not to mention you build tolerance incredibly fast.
Exactly. So we evolved to the new standard, multimodal analgesia, or MMA.
The sources use a fantastic firefighting analogy for this.
It's the best way to understand it. Imagine a house fire. The opioid-only approach is like the fire department showing up with one giant truck and a massive high-pressure hose. You just blast the entire house with water.
You put the fire out, sure.
But you completely destroy the house with water damage in the process. Multimodal analgesia is like sending in a tactical firefighting team. You use a little bit of water, but you also spray fire retardant foam. You dig a trench to stop the spread. You use a chemical extinguisher in the kitchen.
You attack the fire from 5 different angles using different tools.
Synergy. By targeting completely different receptors in the pain pathway at the exact same time, we can use much, much smaller doses of each individual drug. We achieve vastly superior pain control with a fraction of the side effects.
Let's open up that tactical toolkit then. Because looking at the ingredients for this modern cocktail, some of them are surprisingly common. The foundation of this whole high-tech protocol is basically Tylenol.
Acetaminophen, or paracetamol in other parts of the world,
Huh?
it is the humble, unsung hero of the entire strategy.
I think of Tylenol as what I take for a mild headache or a low fever. How does that help with a hip replacement?
On its own, it can't handle a hip replacement, but it acts as a powerful force multiplier. Acetaminophen works centrally, up in the brain. The exact mechanism is actually still debated, but it appears to inhibit an enzyme called KOX3 in the central nervous system.
So it's turning down the heat in the brain itself.
Right. And the clinical data is robust. The sources note that simply adding scheduled, around-the-clock doses of IV or oral acetaminophen reduces the total need for opioids by about 20 to 30%.
That is a massive reduction for an over-the-counter drug.
It lowers the baseline. Then you layer on the NSAIDs, your ibuprofen, celecoxib, ketorolac. These are the heavy anti-inflammatories.
And these work peripherally, right, at the actual site of the cut.
Mostly, yes. Going back to the fire analogy, when the surgeon's scalpel damages your cells, those broken cells release chemicals called prostaglandins. Prostaglandins are nasty little messengers. They sensitize the nerve endings.
They make the microphone more sensitive to sound.
Exactly. NSAIDs step in and block the enzyme cyclooxygenase that manufactures those prostaglandins. They cut the chemical signal off at the source. There was great detail in the sources about patients who are highly inflamed even before surgery.
Right, the patients with high neutrophil to lymphocyte ratios. Explain what that ratio means.
It's basically a blood marker for systemic stress and inflammation. If your neutrophils are elevated and your lymphocytes are low, your immune system is already in a state of alarm. You are biologically a powder keg.
And what happens if you give those specific patients NSAIDs?
Even in those primed, highly reactive patients, giving a dose of intravenous ibuprofen right before surgery significantly reduces the amount of rescue analgesia they need in the recovery room. It dampens the fire before the first match is even struck.
Okay, next in the toolkit, the gabapentinoids. Gabapentin and pregabalin. You see commercials for these all the time for diabetic nerve pain or shingles.
We call these the nerve calmers. They were actually originally developed as anti-seizure medications.
How do anti-seizure meds help with surgical pain?
Remember that relay race of the pain signal? When the electrical impulse reaches the end of one nerve, it has to physically jump across a gap, the synapse, to reach the next nerve.
Right.
To make that jump, the nerve opens up these tiny microscopic gates to let calcium rush in. When calcium enters, it triggers the nerve to spit out a neurotransmitter called glutamate. Glutamate is the chemical messenger that screams pain to the next nerve in line.
So calcium is essentially the key that unlocks the pain message?
Exactly. Gabapentinoids block those specific voltage-gated calcium channels. Think of them as the bouncers at a nightclub. They stand at the door of the nerve and say, "Sorry, calcium, you're not getting in today."
No calcium means no glutamate release, which means the message just stops.
The signal dies right there at the synapse. It completely quiets the electrical chatter between the nerves. We usually give a dose of this 1 to 2 hours before they even roll into the operating room to pre-calm the system.
Okay, moving down the list, alpha-2 agonists. Dexmedetomidine.
Often called Persidex. This is an absolutely fascinating drug. It operates deep in the brainstem, in a tiny little cluster of neurons called the locus coeruleus.
The locus coeruleus.
It's the center that controls your alertness and your panic response. Alpha-2 agonists basically trick the brain into entering a state of natural, non-REM sleep. It provides profound sedation and analgesia. But here's the miracle of it. It does not suppress your respiratory drive.
Unlike opioids.
Completely unlike opioids. You can have a patient lying there who is totally calm, comfortable, practically asleep, but they are breathing completely normally on their own. It is a game changer for safety, particularly for patients with sleep apnea.
Now we have to talk about ketamine, the NMDA antagonist.
What kind of ketamine?
Because obviously it has a reputation, people know it as a club drug or a horse tranquilizer, but in this context, it's a highly sophisticated tool for preventing that spinal windup we talked about.
It is arguably our most potent weapon against central sensitization. Remember the NMDA receptor.
That's the receptor in the spinal cord that causes the screeching feedback loop.
Right. Normally, the NMDA receptor is dormant. It actually has a physical molecule of magnesium sitting in it, acting like a cork in a bottle. But when that massive barrage of pain signals hits during surgery, the magnesium plug pops out, the receptor activates, and the spinal cord goes into overdrive.
And ketamine stops that.
Ketamine acts as a much stronger synthetic plug. It binds tightly to the NMDA receptor and absolutely refuses to let it activate. It literally stops the wind-up phenomenon from physically occurring. And we use it in very low sub-anesthetic doses.
So they aren't hallucinating.
No, they aren't tripping out. It's a microdose that just quietly resets the spinal cord and stops the screeching.
Incredible. And the last pharmacological tool mentioned was dexamethasone.
It's a steroid. We've used it for decades to reduce surgical swelling, and it's one of the best anti-nausea medications we have. But the recent data confirms it also has significant direct pain-relieving properties all on its own. So you get less swelling, less vomiting, and less pain in one push.
That covers the chemical side. But we cannot leave the foundations section without discussing the non-pharmacological side. Because the research is so clear on this. You simply cannot separate the mind from the body when it comes to pain.
It's impossible. The brain is the ultimate processing center. The psychological state of the brain entirely dictates how the physical signal is interpreted.
Anxiety acts as a pain amplifier.
A massive force multiplier. The data is unequivocal on this. High preoperative anxiety is one of the single strongest predictors of severe postoperative pain.
Really?
Yes. If you are wheeled into the OR absolutely terrified, convinced that you are going to suffer, your nervous system is biologically primed. The volume knob is already cranked to maximum before the surgeon even touches you.
It's the nocebo effect.
Exactly. We all know the placebo effect. Believing a sugar pill will cure you actually triggers healing. The nocebo effect is the dark side of that. Negative expectations manifest as negative physical outcomes. If your brain expects agony, it will actively hunt for every minor nociceptive signal and amplify it into agony.
Which means treating the anxiety is literally treating the pain.
It is medical intervention. And the most effective drug for anxiety isn't a pill like Valium, it's education.
Just talking to the patient.
Just removing the fear of the unknown. There was a brilliant statistic in the review. Dedicated pre-op education. Sitting down, looking the patient in the eye, explaining exactly what the procedure is, what they will feel when they wake up, and precisely how you're going to keep them safe. That simple conversation can reduce reports of severe pain by nearly 11%.
That is better efficacy than some of the actual prescription painkillers on the market.
Because it fundamentally downregulates the threat response in the amygdala. When the brain understands the incoming signal, when it can say, oh, this is just normal post-op soreness, I was told to expect this, I am safe, it doesn't panic. It turns the volume down on its own.
Education as medicine. I love that.
It's incredibly empowering.
Okay, so we've established the foundation. We understand the physiology. We have the multimodal toolkit. It seems like a solved problem. But, and this is where it gets interesting, the science is never actually settled.
Never.
Which brings us to section 2, active debate, where the experts are currently fighting it out in the literature.
And there are some heavy fights happening right now. The first one is a classic, decades-old academic battle over timing. It's the debate between preemptive analgesia and preventive analgesia.
Honestly, that just sounds like semantics. Preemptive versus preventive. What is the actual clinical difference?
It sounds like splitting hairs, but the implications are massive. The original theory, preemptive analgesia, was championed by a brilliant researcher named Clifford Wolff back in the 1980s. And the theory was beautiful in its simplicity.
What was the pitch?
The pitch was, if central sensitization is caused by the initial barrage of signals when the scalpel cuts the skin, then all we have to do is block the pain before the incision.
Right. Numb the area completely before the trauma happens.
Yes. If you give a heavy nerve block or a dose of opioids pre-incision, the spinal cord never sees that initial strike. You stop the windup before it can even spark.
It makes perfect logical sense. If the microphone is unplugged when the loud music starts, there's no feedback loop.
It makes perfect sense. So they ran the clinical trials. They gave one group the pain meds before the cut, and the other group the exact same meds right after the cut. And the results were incredibly disappointing.
It didn't work.
It was wildly inconsistent. Sometimes it seemed to help a little, but most of the time it made absolutely no difference in how much pain the patient had the next day. The medical community was baffled. The physiological theory was airtight. Why was the clinical practice failing so hard?
What were they missing?
They were missing the fact that surgery is not a single isolated moment in time. It is an ongoing biological process. The tissue trauma does not end the second the surgeon sews up the incision.
Because the fire is still burning inside?
Exactly. The inflammatory cascade, those prostaglandins and cytokines, continues to trigger pain receptors for days. So if you give a single preemptive nerve block that wears off after 4 hours, but the surgical inflammation lasts for 48 hours, What happens at hour 5?
The barrage hits the spinal cord anyway.
The barrage hits. The spinal cord gets overwhelmed after the surgery instead of during it, and you get the exact same wind-up phenomenon.
Yeah.
You didn't stop it, you just delayed it by a few hours.
Wow. So that realization caused the shift to preventive analgesia.
Yes. The shift went from focusing on the timing of the first dose to focusing on the duration of the coverage. Preventive analgesia says it's not enough to just start before the cut. You have to maintain an unbroken blockade through the surgery, through the recovery room, and into the days that follow.
The sources had a great visualization for this concept, the cyan blue line.
I really love that image. Imagine a chart mapping a patient's entire surgical journey. You want a solid, unbroken cyan blue line of pain coverage that starts in the pre-op holding area, extends steadily through the operating room, and bridges seamlessly into their recovery at home.
You never let the shield drop.
Never let it drop. Use continuous catheters, long-acting medications, and strictly scheduled doses to keep that shield up until the nervous system is completely calmed down on its own.
Okay, debate number 2. And this one is huge, socially and politically. The opioid controversy.
The pendulum swings so hard in medicine. In the 1990s, we had the pain is the fifth vital sign movement, where doctors were essentially pressured to flood everyone with opioids to get their pain scores to 0.
And now we have a horrific opioid epidemic, and the pendulum has swung all the way to absolute terror of prescribing them.
Exactly. And out of that terror has come a very vocal movement called OPFA, opioid-free anesthesia. The stated goal is to conduct major surgeries without using a single microgram of opioids.
Which sounds like a noble goal. Eliminate the addiction risk, eliminate the respiratory depression.
It is a noble goal, but, and the sources were very cautious about this, we have to be careful not to become dogmatic zealots. The current evidence does not definitively show that a strictly opioid-free approach is actually superior to an opioid-sparing approach.
Let's clearly define the difference between those two for a second.
Opioid-sparing means we aggressively use the full multimodal toolkit, the Tylenol, the NSAIDs, the nerve blocks, the ketamine, to reduce the patient's need for opioids by 80 or 90%. But if the patient is still genuinely suffering, we will use a small, targeted microdose of fentanyl or morphine to bridge them to comfort.
You keep the fire extinguisher in the glass case on the wall just in case.
Exactly. Opioid-free anesthesia means you take the fire extinguisher, throw it in the dumpster, and refuse to use it no matter what happens.
And what is the danger in that?
The danger is severe, inadequate pain control. If you are so ideologically committed to avoiding opioids that you allow a patient to suffer on the table or in recovery, their heart rate spikes, their blood pressure goes through the roof, and their spinal cord develops that massive sensitization.
And ironically, isn't uncontrolled acute pain one of the biggest risk factors for developing chronic pain later?
It is the primary risk factor. You might think you are saving them from a potential addiction, but by allowing that acute fire to rage uncontrollably, you might be causing chronic post-surgical pain. You could literally be sentencing them to a lifetime of neuropathic suffering because you were too afraid to use 2 milligrams of morphine when they desperately needed it.
So the scientific consensus right now is balance.
Balance and prudence.
Yeah.
Use opioids strictly as a rescue medication, not as the default routine, but do not ban them from the hospital. They are still an incredibly valid and necessary tool in the kit.
The third active debate in the literature was basically a reality check on our old friend, gabapentin. You framed this in your notes as the curb your enthusiasm moment.
Yeah, that's exactly what it is. For the last 5 to 10 years, gabapentinoids were the golden children of anesthesia. We were practically putting it in the hospital water supply. The protocol was every single surgery gets a dose of gabapentin.
And what changed?
We started looking at the massive outcome data and realized they are not harmless jelly beans. They cause profound side effects: dizziness, severe visual disturbances, and intense sedation.
Which is a massive problem for certain patients.
A huge problem. If you give a heavy dose of gabapentin to an 82-year-old woman who just had a knee replacement, she is going to be incredibly dizzy when she tries to stand up to use the bathroom. And the data shows a significant spike in post-op falls and subsequent injuries.
You might fix the knee but cause a hip fracture.
Precisely. So the debate is shifted from give it to everyone to precision targeting. We're finally asking, does this specific patient having this specific surgery actually need it? If it's a major spinal fusion with lots of nerve manipulation, yes, absolutely. If it's a simple laparoscopic gallbladder removal, probably skip it.
It's a move away from cookie-cutter protocols toward truly personalized medicine.
Which is the perfect bridge into Section 3, Frontiers,
Well,
where the field is heading next.
this is the sci-fi stuff. This is where we stop looking at what is currently standard and look at the wild innovations that could change everything in the next 10 years. And the biggest, most exciting frontier seems to be personalized pain medicine through genetics.
We treat pain incredibly generically right now. You have an adult male who weighs 80 kilos. Here is the standard protocol dose. But we inherently know that is biologically flawed.
Oh, absolutely. My wife can sit in a dentist chair and handle a root canal with barely a flinch. I get a paper cut and I'm complaining about it for 3 days. We are just wired differently.
We are wired differently, and more importantly, our livers metabolize chemicals differently. Pharmacogenomics, the study of how your specific DNA affects your response to drugs, is going to revolutionize this field.
Walk me through this. The notes highlighted a specific gene, CYP2D6.
Yes. CYP2D6 is a gene that codes for a specific enzyme in your liver. And this single enzyme is responsible for metabolizing roughly a quarter of all the medications we prescribe, including major painkillers like codeine and tramadol.
Okay, tracking.
Here is the mind-blowing part. Codeine, in its pill form, does not actually kill pain. It is what we call a prodrug. It is biologically inactive. Your body has to process it. Your liver uses that CYP2D6 enzyme to physically convert the codeine into morphine.
Wait, really? So when I swallow a codeine pill, my liver is basically running a little chemical factory to manufacture morphine inside my body.
Exactly. But because of genetic variation, about 10% of the Caucasian population lacks the functioning copy of that CYP2D6 gene. We call them poor metabolizers.
So they take the pill.
And absolutely nothing happens. The inactive codeine just floats around in their bloodstream. They get zero pain relief, and they probably just get nauseous from the pill casing.
And meanwhile, the nurse or doctor looks at them and thinks, I just gave you a strong painkiller. Why are you still complaining? You must be drug seeking.
Exactly. They get stigmatized as drug seekers when, chemically speaking, the doctor effectively handed them a placebo.
That is tragic. And what about the other end of the genetic spectrum?
The ultra-rapid metabolizers. These are individuals who inherited multiple, highly active copies of that gene. They are super converters. If you give them a totally standard, theoretically safe dose of codeine, their liver instantly processes it and dumps a massive, overwhelming load of morphine straight into their bloodstream.
So they essentially overdose on a normal dose?
Yes. There have been horrific, tragic cases documented of young children dying in their sleep after routine tonsillectomies because they were ultra-rapid metabolizers who were given a standard dose of codeine.
That is terrifying. So the frontier here is what, genetic testing before surgery?
Exactly. A simple cheek swab in the pre-op clinic. The anesthesiologist pulls up your genetic profile on a tablet and says, okay, looking at this, you are a poor metabolizer for codeine, so we won't even bother with that, but you are a hyperresponder to NSAIDs, so we will lean heavily on ibuprofen.
It takes the guesswork out entirely.
Complete precision. And it's not just genetics. The frontier is also exploring timing. Chronopharmacology.
The rhythm of the body.
Right. Our bodies are not static machines. Our hormone levels, our baseline pain thresholds, and our liver enzyme production constantly fluctuate on a 24-hour circadian rhythm.
So you're saying a surgery performed at 8 a.m. might have a different biological outcome than the exact same surgery performed at 4 p.m.
The data strongly suggests it does. We know that certain local anesthetics bind more effectively and last longer at specific times of the day. We also know that human pain tolerance generally drops significantly in the late evening.
So in the future, a scheduling AI might look at your chart and say, this is a highly painful orthopedic surgery. We must schedule it for 9:00 a.m. when the patient's natural cortisol and endorphin levels are peaking to provide maximum resilience.
Or we might program the IV pumps to deliver pain medications on a specific curve that matches the circadian peaks and valleys of the patient's individual pain cycle. Rather than just a flat hourly drip, it's adding the fourth dimension time to the prescription pad.
Another frontier that really stood out in the sources was this concept of pain prehabilitation.
This is a massive shift in how we view the patient's role. We all know about rehab, the physical therapy you do after surgery. And we are familiar with physical prehab, getting your heart and lungs strong before surgery. But pain prehab is about actively training your nervous system.
It sounds like putting on mental armor.
It is mental armor. There's a huge psychological component. We're starting to prescribe cognitive behavioral therapy, CBT, and structured mindfulness training for weeks before a major operation.
Literally teaching the brain how to process the pain signal before it happens.
Teaching the patient how to cognitively disengage from the catastrophic fear response. And the clinical evidence is surprisingly robust. Patients who practice these specific relaxation and cognitive reframing techniques actually require left chemical anesthesia during the surgery and report significantly lower pain scores afterward.
Because they altered their neural pathways through practice.
Yes, but there is also a critical chemical side to pain prehab, and this is specifically targeted at patients who are already on daily opioids for chronic pain.
Ah, right. The sources called this the paradox of opioid-induced hyperalgesia.
It is a brutal paradox. If you take a drug like oxycodone every single day for chronic back pain, your nervous system doesn't just accept it, it fights back against the suppression. It chemically upregulates its pain receptors. It essentially tries to shout louder to overcome the muffling effect of the drug.
So the medication you are taking for pain actually physically makes you more sensitive to pain over time.
Yes, your baseline sensitivity skyrockets. A minor pinprick feels like a knife stab. So when these specific patients go in for major surgery, their postoperative pain is notoriously uncontrollable because their internal alarm system is completely broken and hypersensitive.
So what is the prehab strategy for them?
A highly structured, supervised tapering process. We aggressively wean them down off their opioids in the weeks before surgery.
Which sounds completely counterintuitive. You're telling someone in chronic pain to stop taking their painkillers right before someone cuts them open.
It is a terribly difficult conversation. But by lowering the dose for a month prior, you allow those receptors to reset. You restore the body's natural sensitivity, so when they wake up from surgery, the acute pain medications actually work again.
That requires an incredible amount of trust and communication between the patient and the care team.
It does. It requires a dedicated pain specialist. But the outcome differences are night and day.
Now, we can't discuss frontiers without talking about the actual technology in the operating room. Specifically, the ultrasound revolution in regional anesthesia.
This piece of technology has fundamentally altered the daily existence of an anesthesiologist.
For the listener who might not know, explain exactly what a regional block is.
Think of when you go to the dentist and they inject Novocaine to numb just the right side of your jaw. A regional block is doing that exact same thing, but for your entire arm or your whole leg or one side of your abdomen. We are blocking the major highway of nerves leading to that specific territory.
And how did doctors used to do this before the tech?
Almost completely blind. Well, we used anatomical landmarks. The doctor would feel for your pulse, draw a line from a muscle, measure 2 centimeters over, blindly advance a needle through the tissue, and basically ask the patient, hey, does that feel funny down your leg?
Lots of trial and error.
It was an art form, but it had a significant failure rate. Sometimes you miss the nerve entirely. Now, we use high-definition portable ultrasound machines. We place the probe right on the skin, and we can look at a monitor and physically see the actual nerve bundle. It looks like a little honeycomb or a cluster of grapes sitting in the muscle.
So you watch the needle go in live on a screen.
We watch the tiny needle tip advance millimeter by millimeter. We maneuver it precisely next to the nerve. We inject the local anesthetic fluid, and we watch it spread out and surround the nerve like a dark halo. We know with 100% certainty that we hit the target.
And this visual precision has unlocked these new procedures called fascial plane blocks. What are those?
This is the true frontier of regional anesthesia right now. Instead of hunting for one tiny specific nerve to numb an arm, we are injecting large volumes of dilute numbing medicine into the actual planes, the microscopic spaces between major muscle layers.
Like spreading mayo in the layer between the turkey and the cheese in a sandwich.
As a brilliant analogy, the major nerve networks run right through that exact filling layer. If you flood that fascial space with anesthetic, for example, the TAP block for abdominal surgeries, or the erector spinae block next to the spine, you can numb an absolutely massive territory of the body safely.
So you can have someone's entire abdomen sliced open and the whole abdominal wall is just dead to sensation.
Completely numb. And here's the best part. We can thread a catheter, a tiny flexible tube as thin as fishing line, into that space. We connect it to a computerized pump, and it continuously drips numbing medicine into that muscle plane for 3 full days.
So the patient literally goes home with a continuous pain pump attached to them.
Yes, they go home, they sit on their couch, they play cards with their kids, instead of writhing in a hospital bed hitting a morphine button. It is the ultimate realization of that cyan blue line of uninterrupted coverage we discussed.
That is astonishing. Okay, before we leave the frontiers section, I have to ask you about the alternative interventions mentioned in the research. Because when I saw aromatherapy and music therapy in the clinical notes, I was a bit skeptical. Is that real hard science?
Do not knock it until you look at the p-values. The sources explicitly cited randomized controlled trials showing that exposure to rose oil and other specific essential oils provided statistically significant reductions in postoperative pain scores.
How does smelling a flower stop a surgical incision from hurting?
It ties right back into brain anatomy. The olfactory nerve, your sense of smell, is wired directly, physically, into the limbic system of your brain. That is the primitive emotional center. It completely bypasses the logic and reasoning centers.
Okay.
If you can use a specific scent to trigger an immediate hardwired calming response in the limbic system, you instantly downregulate the patient's anxiety.
And as we established earlier, less anxiety directly translates to less physical pain.
Exactly. It lowers the amplifier volume. The same mechanism applies to music therapy. It's not just a pleasant distraction. Actively listening to familiar, preferred music engages multiple areas of the cerebral cortex, and it literally competes with the ascending pain signals for the brain's processing power. The brain only has so much bandwidth.
So the future of a major surgery is taking a cheek swab for your DNA, putting on a VR headset for mindfulness training, an AI calculating your perfect dose time, and waking up smelling roses while listening to your favorite album.
All while a perfectly placed ultrasound nerve block keeps your body completely numb. That sounds like a radically better future to me.
It really does. But we have to ground all this high-tech optimism in the reality of the present. We've talked extensively about the biology and the science, but we need to talk about the real human beings.
Section 4. Implications. The ethics, economics, and society.
And you cannot have a conversation about pain management today without confronting the massive, devastating shadow of the opioid epidemic.
We touched on this briefly, but let's dive deeper. Because surgery is very often the gateway, isn't it?
It is the absolute first exposure event for millions and millions of people. Think about a healthy high school teenager who tears an ACL playing soccer, or a college student getting their wisdom teeth extracted. These are people who have never taken a narcotic in their entire lives.
And they walk out of the pharmacy with a bottle of 30 Percocet.
Right. And maybe they are hurting, so they take 5 or 6 of them over the first 2 days. The pain stops. What happens to the other 24 pills?
They just sit in the back of the medicine cabinet. They sit there for years. And maybe that teenager has a terrible depressive episode a year later and remembers how those pills made them feel numb, or their friend comes over and soups in the bathroom, or a younger sibling finds them. That seemingly innocent prescription bottle is the primary supply line for community diversion and addiction.
There was a specific statistic in the data that completely terrified me. 10% of cardiac surgery patients are still actively using opioids 90 days after their surgery.
It is a staggering, heartbreaking number. These are mostly adults who were entirely opioid naive before their bypass surgery. 3 months later, long after the sternum is healed, you're still taking narcotics daily. By medical definition, that is the genesis of a brand new chronic user.
So surgeons and anesthesiologists are effectively the frontline gatekeepers of this epidemic.
We are the stewards. We hold a massive ethical responsibility, and that changes how we practice. It means writing drastically smaller prescriptions, giving a patient exactly 5 pills for breakthrough pain, not 30 just in case. It means rigorously employing that multimodal approach so they hopefully never even need to open the bottle.
And the guidelines strongly emphasized co-prescribing.
Naloxone, brand name Narcan. The new ethical standard is, if you are sending a vulnerable patient home with a high-dose opioid prescription because they had a massive surgery, you must simultaneously prescribe and send them home with a reversal antidote.
Just as a safety net.
Exactly. You pray they never need it, but you put the fire extinguisher in their house. And we also have to actively educate families on how to safely dispose of leftover pills at pharmacies rather than just leaving them in the drawer.
Then there is the sheer economic burden of all this. We talked about chronic post-surgical pain, or CPSP.
The rates are shocking. Up to 50% of patients develop some form of chronic pain after highly invasive, nerve-heavy procedures like a thoracotomy, where they open the chest ribs, or an amputation or a mastectomy.
50%. That is a literal coin flip on whether your life is permanently altered by pain.
And think about the macroeconomic cost of that to society. A 45-year-old mechanic who has a chest surgery and can never return to work because they have severe burning neuropathic pain in their ribs. The loss of income, the disability payments, the severe clinical depression, the endless healthcare utilization trying to fix it.
It costs the system millions per patient, which puts the cost of the actual drugs into perspective.
Exactly. Hospital administrators are notoriously stingy. They hate paying $40 for a vial of intravenous Tylenol or $100 for a high-tech ultrasound nerve block kit. They want to use the $2 morphine. But if that $100 nerve block completely prevents the windup and saves society a lifetime of disability payouts, it is the best financial investment in all of healthcare.
It's the core philosophy of ERS, right? Enhanced recovery after surgery.
Get them moving, get them eating, get them out of the hospital. Pain relief isn't just about subjective comfort anymore. It is about physical function. If a patient isn't in agony, they will get out of bed and walk down the hall.
And if they walk, they don't develop deep vein blood clots.
They don't get blood clots. They expand their lungs so they don't get pneumonia. Their bowels wake up faster. They recover, and they go home 3 days sooner. Excellent pain control is the engine of recovery.
Finally, we need to spend some time talking about the highly vulnerable populations, the ethics of specialized care, because you obviously cannot treat a frail 90-year-old with the same protocol you use for a 30-year-old athlete.
The frail elderly are an immense challenge. Their physiology is brittle, the liver clearance is slow, the kidneys are weak. But the biggest, most terrifying danger here isn't just the physical pain, it's postoperative delirium.
My grandfather actually went through this. He went in for a routine hip pinning after a fall, and for 3 solid days afterward, he was hallucinating. He didn't know who my mom was. It was incredibly traumatic for the family.
It is deeply traumatic,
Yeah.
and it is physically dangerous. Delirium is strongly linked to higher mortality rates and a significantly accelerated slide into long-term dementia. And here is the brutal catch-22 we face. Uncontrolled severe pain directly causes delirium.
But the drugs you use.
But the heavy drugs we use to treat the pain, the opioids, and especially the sedatives, also directly trigger delirium in an aged brain.
So you are completely damned if you do and damned if you don't.
You have to walk an absolute tightrope. The modern protocol is strict. You avoid benzodiazepines like Valium or Versed entirely. They're absolute poison for the elderly brain. And you use opioids incredibly sparingly.
So what do you use? The notes mentioned clean drugs.
We rely on drugs that undergo spontaneous molecular breakdown, medication like remifentanil, for example.
How is that different?
Most drugs require a healthy liver or kidney to filter them out of the body. Remifentanil doesn't. It is broken down directly by enzymes floating in the blood itself. It just dissolves on its own in minutes.
Because an 88-year-old's liver simply might not be up to the task of clearing a heavy narcotic, and it would just build up and cause delirium.
Precisely. And in this population, the non-pharmacological human touch matters more than any drug. Hand-holding, reorienting them continuously, making absolutely sure they have their hearing aids and prescription glasses put back on the second they wake up so they aren't sensory deprived, having a familiar family member at the bedside.
Basic human connection.
Yes. These aren't just nice gestures. They are clinically validated, evidence-based medical interventions to stop delirium.
What about the exact opposite end of the age spectrum? Pediatrics, babies, and toddlers.
Kids are driven almost entirely by fear. Fear of the unknown and profound separation anxiety. A 2-year-old doesn't have the cognitive ability to understand, this doctor is fixing my hernia so I feel better.
They just know. My mom just left the room, and this giant stranger in a mask is holding me down.
It is sheer terror. So distraction is our primary preoperative drug. Video distraction is massive.
An iPad is a medical device.
Literally, yes. We use iPads, light-up toys, and we heavily emphasize parental presence at induction, allowing mom or dad to physically hold the child on their lap while they breathe the sleepy air through the mask until they drift off.
And medically, how do you handle their pain?
We use a lot of regional anesthesia, specifically caudal blocks. This is a brilliant technique where, once the child is fully asleep, we inject a long-acting numbing medicine right at the very base of the spine near the tailbone.
So it completely numbs the entire lower half of their body.
Yes. It is incredibly safe and highly effective for common pediatric surgeries like hernia repairs, circumcisions, or urology procedures. The child wakes up and they feel absolutely nothing below the waist. No pain at all.
So they aren't thrashing or crying in recovery.
They aren't stressed. And because the physical body doesn't feel the trauma, the developing brain doesn't panic.
And the last specific group to cover, and perhaps the most stigmatized group in the entire healthcare system, is the opioid-tolerant or dependent patient.
This is a profound test of empathy for the medical system. These patients, whether they're on prescription methadone for chronic back pain or buprenorphine for a history of substance use disorder, are constantly labeled as difficult or drug-seeking.
The nursing staff gets nervous. This guy is on a massive dose of oxycodone F baseline. What on earth do we do with him after surgery?
The clinical reality, the strict biological math of the situation, is that they need more medication than a normal person, not less.
Because of that receptor upregulation we talked about earlier.
Exactly. Their receptors are numb to normal doses.
Yeah.
If you give them the standard 5 milligrams of oxycodone, it does absolutely nothing. They need significantly higher doses just to get back to their normal everyday baseline, let alone treat the massive new surgical trauma.
And the Guttlein rule in the guidelines for these patients is do not stop the baseline.
Never, ever stop their baseline medication. If a patient takes 80 milligrams of methadone every single day to function, you must give them that 80 milligrams on the morning of their surgery.
What happens if a doctor gets nervous and holds it?
If you stop it, they crash into severe acute opioid withdrawal on top of the massive physiological stress of surgery. Their heart rate explodes, they become violently ill, their pain goes totally out of control. It is a preventable physiological disaster.
And there has been a major recent shift regarding the drug buprenorphine, hasn't there?
A huge life-saving shift. Buprenorphine, often known as Suboxone, is a drug used to treat opioid addiction. For years, the standard surgical guideline was to force patients to stop taking it 3 full days before their surgery.
Because doctors thought it would block the anesthesia drugs.
Right. They thought it would prevent the post-op pain meds from working. But stopping it was a nightmare. Patients would go into withdrawal, they would be in sheer agony, or tragically, the stress would cause them to relapse into active street drug use.
And what do the new guidelines say?
The new enlightened consensus is, continue it. Do not stop it.
Even on the day of surgery.
Even on the day of surgery, it stabilizes their brain receptors, it keeps the craving and the withdrawal away, and we now know we can safely add other multimodal pain meds right on top of it. It is infinitely safer to keep a vulnerable patient chemically and psychologically stable than to recklessly rock the boat right before a major trauma.
Listening to all of this, going through the foundations, the debates, the tech, it really feels like the central unifying theme of this entire field is respect.
I think that's true.
Respect for the sheer complexity of the human nervous system, respect for the individual patient's unique genetics and psychological history, and a very healthy respect for the awesome power of the drugs we are using.
That is a truly beautiful way to synthesize it. The field of pain management has fundamentally transformed from a crude, simple act of numbing a body part to a highly complex, holistic protection of the entire human person.
We aren't just silencing a symptom on a monitor anymore.
No. We are actively protecting the architecture of the mind, shielding the circuitry of the spinal cord, and preserving the future quality of life of the patient.
Because it's not just about surviving the operation and getting through the surgery. It's about who you are and how you function when you finally come out the other side.
Exactly.
Before we wrap up, thank you to all our partners, sponsors, and scholars who made this podcast and the research possible. We're truly grateful for your support. And to our listeners, thank you for being part of this journey with us. We hope you enjoyed today's discussion. If you did, be sure to subscribe and support us on Patreon. And of course, you can write to us in comments if a specific topic needed to be covered, which help us all to grow.
Thanks for listening, everyone. Take care of yourselves.
Until next time, stay curious, keep learning, and let the search for wisdom guide you forward. Have a great day.